Hello, and welcome back to the Postpartum Years podcast. I am your host, Dr. Mary Ellen Kramp. I'm a physical therapist and a pelvic health specialist. Today, we are going over part 2 of mastitis. So let's jump right back into it. Looking at current recommendations, the Academy of Breastfeeding Medicine back in 2022 when they set this out are, again, very big on antibiotic stewardship, and those antibiotics should only be used when that mastitis has become infectious. They are recommending use ice, again, like we are beating pretty hard into this session. Use ice, not heat. And they also recommend specifically feeding the baby at the breast rather than pumping if possible, because it is such a different strategy than the baby removes the milk differently than a pump will remove it.
The act of a baby latching onto the breast is more than just removing the milk. It is the sharing of saliva. It's the good and the bad bacteria, like the good bacteria interacting with the nipple and the areola and the breast. And it's very different. Like, a baby, when they're latched to the breast, they're not nipple pulling, they're breastfeeding. And so they're making compressions like deeper on the areola. And the pump, it's literally just pulling the nipple, pulling the nipple, pulling the nipple. And that's it. And also, I think that we're going to cover this in a subsequent slide, that people are often over-sterilizing their pump parts. And that's killing the good and the bad bacteria, and it's allowing the bad bacteria to have a party with the pump parts. And so you put that on your breast, and you're increasing the chance for that breast dysbiosis, where there's too much bad bacteria and not enough good bacteria to happen. A baby in the breast and just naturally going to the breast, you're like, that's how the body should do it. And so it works better.
When the baby latches on to the breast, the saliva from the baby gets taken up partially by the nipple and into the lactiferous ducts, and the bacteria on each end are chatting with each other and informing. And the studies showed that the milk is different based on what's going on. So the bacteria is informing, hey, the baby's kind of a little off. It's kind of like the Oura ring.
Yeah.
The baby's a little off. Can you make a little bit more of this? And so the milk will change in its content based on that information, that communication back and forth between the baby's saliva and the mother's nipple. I love that research.
Yeah, it's fascinating.
All right, Kat. I know you are not someone who is feed the baby by the clock kind of person.
Nope. And there's some unlearning that people have to do. So in the hospital, we recommend, this is what doctors, nurses, people are telling moms. They're saying, okay, you feed every 2 to 3 hours, 15 to 20 minutes on each side, and then you do it again. Well, babies can't read the clock. They didn't sign up for that. They didn't read the textbook that says that that's what people should do. And so therefore they don't know better. They say, my tummy feels empty. I need to eat something. And they cue. And so really cue-based feeding. And in some places, like even on this slide, it says, feed infant on demand. Really, the beauty of breastfeeding and direct feeding at the breast is when you're in sync with your baby and you are anticipating your baby's hunger before they're actually showing you late signs of hunger, which would be crying, right? So you notice that baby in your arms is going, mwah, mwah, and then you're like, okay, let's latch baby. And when you do, the baby has that positive reinforcement. You're like, okay, that's what that looks like. Another thing is trying to get the breasts to be empty. So breasts are never quite empty. That when a baby or a pump goes onto a woman's breasts, that suction and that nipple pulling and that stimulation sends signals to the brain to produce more milk. There was a research study, and I might be quoting it incorrectly, but from my memory, it said that 70% of milk production for a breastfeeding session happens while the baby's at the breast. And so if that's the case, so there might have been like a 30% like residual, and then the rest of the feed's happening. And if the baby kept suckling actively and, pulling the nipple and stimulating those hormones to talk to the brain to produce more milk, it's going to keep on making milk. And then also like pumping to empty. So there's some recommendations to pump to empty. Again, breasts don't really get empty. And if they do stop flowing, if you've pumped and there's no flow, and then you go 5-10 minutes past, which you'll see that recommendation places, you're causing oversupply, hyperlactation, which is going to make the swelling, which is edema, and the inflammation worse. And we're going to have more plugged ducts, we're going to have more mastitis, and the cycle will continue.
Looking at things to do, one of those things is hand expression. Another is pumping only the amount that the baby will drink and not going for stashing it in the freezer. And again, ice and lymphatic drainage.
Yes.
And I'm going to hop onto my soapbox here. So I brought my soapbox, and I'm going to hop on it.
Okay.
Because I was informed by my producer, Cameron, that we're probably going to have to somehow blur the nipples that we are going to show in this video. And I would like to, lodge a formal complaint here, because all mammals have nipples. We all have nipples. Why is it that only 50% of the population has to hide their nipples? And it's the 50% that has the functional nipples.
Yes.
Why? Why do we have to hide them? Why? Why can't we show, especially in the context of education, how to do hand expression? Further on, we have what nipple bleb looks like,
Yes.
and we can't show that in social media. Explain.
Yeah.
Explain why the stupid non-functional nipples can be shown, but the functional nipples cannot.
So my soapbox commentary, to follow up your soapbox commentary, is that breasts and nipples are multifunctional, like hands. You can use hands for sexual purposes, and you can also use them to feed yourself or clean yourself, or as a tool, right? Breasts, they can be used sexually, yes, and they also are functional, and they have a purpose to feed babies. And I get upset sometimes where I'm in a setting with lactation consultants. They're like, breasts aren't sexual. They're only for feeding babies. And I'm like, they can be both.
No.
They can be both. And why can't we have discernment of what's sexual and what is educational in these platforms? And once again, like that, the algorithms, the AI, the people that are offended or disgusted by looking at a functional lactating breast, they'll report it, and then that's what we're seeing. Or even like the algorithms or AI is like screening it without looking and thinking of like context and
no discernment.
Having some discretion of like, okay, well, in this context, that's not sexual. It's educational. We should have it. Yeah.
Yeah.
So anyways, our soapbox lectures
Yes.
are done.
Yeah, soapbox is done. We shall step down and move on to minimizing breast pump usage.
Yes.
All right, I'll let you take this next one,
Okay.
Kat, on minimizing breast pump usage.
So again, we were talking earlier on about stash culture, about starting pumping early on in your breastfeeding journey, like while you're still in the hospital, when, without guidance. And again, what we were talking about with like that whole dysbiosis of like the bad bacteria versus the good bacteria, the direct latching helps good bacteria. Using breast pumps, sterilizing, over cleaning them causes bad bacteria to overgrow. So it's just simply we want to, and I love that that is included in this recommendation, and I love that the Academy of Breastfeeding Medicine has made this recommendation. But I also just need to, once again, another soapbox is we don't have paid parental leave in the United States. And so to make a strong advisement to people to promote physiological normal lactating, which is direct breastfeeding with having baby at the breast, when we don't have paid parental leave in this country, kind of rubs me the wrong way. So it's like, yes, I agree with them. It's better to do this. And also, how are we going to do that without paid parental leave when people have to go back to work and they have to pump and the baby has to get a bottle? How does this work? A friend of mine that's in advocacy, she says, like, the Academy of Breastfeeding Medicine likely said that and made that recommendation to affect legislation. But like we said about research, it's going to take a long time for that to trickle down. And what newly postpartum or pregnant people are going to see is that they're doing something wrong. And no, they're just surviving in the world that we live in. And so, yes, minimizing breast pump usage is a great idea in theory. And when we have paid parental leave, I will be happy to keep pushing that even more. But right now I'm dealing with the real world where that may or may not be possible. Another issue with pumps is the excessive duration of time that we hadn't covered previously. We covered improper flange sizes and also the suction being too high. But just for the general public to know this information, and I'm not telling you to do this if you are currently lactating, I'm just giving it as an example. It is better for your breast health and your milk supply to pump for 10 minutes every hour for 4 hours than to pump for 40 minutes every 4 hours. Once again, I'm not saying that anybody should do that. Please don't make an Instagram or a Pinterest post that, and quote me. That's not the recommendation. It's just a way to understand what's better. So it's better to have shorter, more frequent breast milk removal than to have less frequent, longer milk removals.
Again, wear appropriately fitting bras. That's going to go along, and clothing.
Yes.
Because clothing, I see a lot of women in tight-fitting sports bras.
Yes.
And that is not going to be terribly helpful with, preventing mastitis. You want to, you want to support the breasts, but you don't want to crush them.
Yeah.
So,
or
try to consider, are you really compressing them, or are you, giving them a lift and supporting them? Some of us have rather mine grew down looking at the floor straight down. So I need a lot of support. Others are perky as the day is long and they don't even need a bra. So just kind of consider, what is your situation? What size do you need? What is going to be helpful for you?
What I see women doing is their rib cage expands during pregnancy, and they buy the band extenders, but your breast shape and the cups of the bra, it also changes. And then you wind up having a lot of compression and a lot of issues in that area. So it might feel more comfortable and you can breathe because you're not just tying, your rib cage too tight with a bra. But you also need to think of how the breast falls into the cups of the bra and etc. And really, women in general, whether or not you're lactating, pregnant, whatever, we all need to be measuring our chests to have properly fitted bras and buying new bras more frequently than we do. And I too am guilty of it. I'm we all need to do it more, especially when we gain or lose weight. Sometimes we might need all right, I've got PMS and my breasts are swollen, maybe we need a slightly bigger bra for that period of time and a slightly smaller bra when our breasts aren't so sore and swollen. And just, we need better bras.
Be kind to the breasts.
Yes.
And remember, the breast is full of glands and it's not a muscle.
It's not a muscle.
Please treat it kindly.
Yes, be
please
gentle.
Treat it kindly.
Like, I would rather people, when they're experiencing plug ducts and mastitis, be way too gentle with their breasts than to cause damage by being what they think would be okay. So I'd err on the side of gentle.
Alrighty, and moving forward, we covered a lot of this earlier. Avoid doing saline soaks, avoid castor oil, avoid other topical products because it can really be problematic for the skin. It can cause more edema, it can cause more redness, and it can kind of break down the tissues themselves. So definitely avoid all the soakings and the oils and the topical creams and stuff, and avoid that routine sterilization. Yeah, if it's every once in a while, it's fine to do.
Like once or twice a week.
Soap and water.
Yeah, once or twice a week sterilize, but not every single day, not multiple times a day, not everything every single day.
Yeah, just as, we used to have all the antibiotic soaps and everything, and then they realized, oh, gee, look, we are creating a population of people with tons of allergies. We need, our systems we're like 90%, bacteria and viruses and stuff. We're like, our cells are only a fraction of what we are as human beings. And that all needs to communicate with the environment. So over-sterilization can lead to allergic issues in the future and other problems.
Another thing on this slide that I need to draw attention to is mastitis is not contagious. Also, almost all of the medications that are prescribed for treating mastitis are not going to harm baby in the breast milk. And that is something that I see this in the hospital where I work out, where somebody comes in for mastitis. They are told to pump and dump because they're on such a strong dosage of IV antibiotics. And I look up the medications, and the medications are fine. And the mom doesn't need to throw away her milk and waste her time and energy. The whole pump and dump thing must have come from a man that never, lactated, because wasting milk is just not okay. It's just not okay. And there's usually not a reason to waste it. So it just drives me insane.
And I found it interesting talking to the moms who have toddlers that they're still breastfeeding and the ones that are able to speak. And they will often say that the milk tastes salty. So it's okay, but it's they're just like, the milk is salty.
Yeah. And maybe one day we'll have research that explains clearly, like, why is it more salty when there's mastitis? Like, I don't know. Yeah, there's a lot we don't know about lactation and breastfeeding. So
another thing that we came across in the research is that mood or anxiety disorders are they are prevalent in the postpartum population, and this particular population has a higher likelihood of having mastitis as well.
They are probably hyper fixated on measuring and pumping and watching and scheduling and like controlling things so that they feel better. And I see that in my clients all the time. And that might be part of the reason why that does lead to more mastitis and more plug ducts and more issues.
Another thing that the Academy of Breastfeeding Medicine recommends is probiotics, and they should contain, oh my gosh, let's see, Limosilactobacillus.
I'm thoroughly enjoying you trying to pronounce this stuff, because when I have a hard time pronouncing like anatomical terms, I'm always asking Mary Ellen to help me
You're always asking
pronouncing
me.
it, and to see you stumble just makes me happy.
Yeah, medications, I'm a PT. I don't do drugs.
Yes, you do anatomy.
So, this is where I'm going to draw the line. So, Lumicil lactobacillus fermentum, and then Ligilactobacillus salivarius.
Yes.
So, that's the best I can do.
Yep.
I hope I did not butcher those two fairly well.
You did better than I would have.
Those are the probiotics. Probiotics that the Academy of Breastfeeding Medicine recommends.
Yeah.
Other recommendations are going to be treating the pain and inflammation. And again, we've covered this. Ice, get the bag of frozen peas out. For the inflammation, can also use ibuprofen or acetaminophen or sunflower lecithin. And those, if it's something you can't take ibuprofen or you can't take acetaminophen, please don't. Or if there's any question at all, please check with your doctor or pharmacist about what you'd be able to use as far as pain and inflammation. But these are things that are out there more for general public.
Yep. Over the counter.
Yes. The next recommendation out there is to definitely treat oversupply, which I always refer these patients when I'm working with them with mastitis, and I can see that oversupply is a major issue for them. I always refer them back to their IBCLC to help them manage and decrease the amount of milk that they are producing.
And I think we're going to have another podcast in the future where we're going to go more into what oversupply is and management. So look forward to that.
Yeah, we're going to have one on oversupply. We're going to have one on undersupply. There's a lot to go through on that. Alrighty, and here's another one that's probably going to be blurred, because God forbid I want to actually, educate and show someone what that nipple bleb would look like. Kat, do you want to go into blebs? Because you deal with this a lot more than I do.
So what I really love about the Academy of Breastfeeding Medicine recommendation about blebs is they say don't try to pick at it or unroof it. That's going to cause more inflammation. It can cause bacteria or viruses to enter through that open wound. When I first heard that recommendation a few years ago, I was like, but sometimes you just need to pop it, And what I've seen in my clinical practice, once I started enacting that recommendation not to pop it, is that really 90% of the time, conservative methods will help it to go away on its own, where you don't need to actually lance it with a sterile needle or pick at it. What people do before they even come to me when they're having that issue is they often pick at it. And I actually had a client rub it with a washcloth repeatedly. Every time it would come back, she'd rub it, and she had scar tissue on her nipple that was causing the nipple pore to be narrow, so that it just kept on happening. So once again, be gentle with your breasts, be gentle with your breasts, be gentle with your nipples, be gentle with them. Okay.
Uh-huh.
They don't do well being, handled roughly. They just don't. Bad things happen. Sometimes the one caveat for that, whole, the fluid stuff, earlier we were talking about not using lotions, potions, ointments, or creams that it can macerate the tissue. Sometimes in some situations, I still will recommend putting some coconut or olive oil on your nipple and then putting a disposable breast pad on to help soften and work out the bleb if it's persistent and we've tried other things first, conservative methods first.
Right. Yeah. So on the next slide, we have the outdated recommendations are,
Yep.
picking off the bleb
Yep.
or using the haka with Epsom salts.
Hmm.
And the current recommendations, of course, are not to pick it off. The Academy of Breastfeeding Medicine also recommends oral lecithin or a topical steroid,
Yes.
which I know you have your issues about the topical
So the topical
steroids.
steroid, anything that's going to make a mom have to wash or clean her breast before breastfeeding, it just creates a barrier and a hardship on the mom to keep doing something. In addition, I have literally sent an exact copy with highlighted excerpts of the Academy of Breastfeeding Medicine's protocol to OBs and midwives when I'm sharing a patient with them, and they don't prescribe the what I recommend from the protocol. They're like, no, 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 we're not going to do that. So not only is it another step that mom has to take to be able to feed her baby, but it's also not easily gotten from providers yet. So research and protocols, they happen, and then it takes like a good 10, sometimes up to 20 years for it to go down into main everyday practice where like it's
Hmm.
common knowledge for doctors and prescribing physicians. So I don't disagree with a topical steroid. I just the way that they're mentioning it is like, yeah, people will just get it. No, it's hard. It's hard to get accurate breastfeeding medicine for breastfeeding issues sometimes.
Alrighty, moving on to abscess. Again, something I'm not going to treat, something Kat's not going to treat. The only person who should be treating this is a breast doctor. So if you are at the point where you have an abscess, or your IBCLC finds it, your PT or OT finds it, a nurse finds it, whatever, you need to see your doctor now. If you can't get to your doctor, you call the office or it's the weekend, go to the ER. You need that addressed. It's an infection. It's a bad infection. It's going to need a drain. It's going to need antibiotics. No way around it. So one thing that Kat and I and our buddy, the speech language pathologist Barbara, are really big on is the support team. So we have the IBCLC who does lactation management, prevention of reoccurrence, latch assistance, infant growth, family support, pumps, whatever is needed there. And then you have PT, OT doing lymphatic drainage, fascial release. I also do vascular release. There may be some massage in there. OT can also do sensory motor support for the infant. Pediatrician is going to help with medication and referrals, and an OBGYN or midwife can do some medical intervention.
A speech language pathologist would be managing like infant skills assessment, oral motor, sensory interventions, and also SLP's jam is how to get infants, a SLP that specializes in infants, is how to get the safest way to feed the baby. And so that's their gift, that's their talent. And then for family support, it takes a village to feed a baby. So they're going to offer encouragement, offering gentle reflection or something, or maybe like showing the mom like, hey, like maybe stop suffering, and this is harder than it really should be. So maybe you need to go see another provider to make it this easier and better. And dentists sometimes, when there is an oral restriction, will do a surgical intervention to cut either a lip tie or a tongue tie that might be a part of the picture of why there's poor milk removal when baby's at the breast.
Alrighty, so we took a little bit of break after that last slide, and we are now in a new location. So if things look a little bit different, that's why. But we're going to jump right back in. And right now we're going to discuss PT's role in mastitis. And one of the things that PT can really do that we've been doing for decades is manual lymph drainage. We've been doing this a lot with breast cancer, and it works perfectly as well with mastitis, because a lot of the women who are dealing with mastitis are also dealing with poor lymph drainage within the breast. Sometimes there is connective tissue restriction. Um, I always joke with my patients who were former soccer players, like, okay, I totally see the reason why you're having issues with mastitis now, because they tend to have a lot more restriction in through the breast on a connective tissue basis from all of those chest hits with the soccer balls. And this is another one of those issues where I really want to do research and see how many women who were previous soccer players have issues with mastitis, because I bet it is higher than the average population because of the physical restrictions that are present in the breast. Um, and so between the lymphatic drainage and the fascial releases that I need to do, um, that really needs to help to drain the breast. That really helps with the mastitis if it is from a more physical issue. If it's active infection, we're not going to be able to fix that. But if it's before that, where there is compression in the tissues and there's poor flow out of the tissues, then the manual lymph drainage and the fascial releases can really help to alleviate what's going on within the breast.
I'd like to just comment about the manual lymph drainage for people. I am not a PT, but I've worked with you very closely. And so I've become quite skilled with lots of practice doing manual lymph drainage. And for me, the most important part of it is I can't really tell what else is going on in the breast until I've done the manual lymph drainage. Sometimes I can't even tell where the clog is. I can't tell like anything. It's like it's very hard because when there's lymph drainage and clogs and everything, like the breast just becomes firm in like an area, and so I can't even like feel the glandular tissue or anything. And so doing the manual lymph drainage first before any other treatments for me as a non-PT who does not know how to do the fascial and or visceral, I don't know those things. It helps me know what needs to be done next. And often it's referring to you if my manual lymph drainage technique doesn't work.
Yeah, because if your manual lymph drainage technique is not working, that is usually because there's some fascial restriction in the way, not allowing it to drain.
Hmm.
But that is one thing that I teach when I'm teaching vascular releases, I'm teaching lymphatic releases, I'm teaching fascial releases. Is yeah, if things feel really boggy and you just feel like you can't feel anything, try draining it. If it's not draining, something is blocking it from draining. So
Yep.
that's when we have to kind of jump in and do some more fascial releases in order for the lymphatics to be able to drain. So poor infant milk removal can cause plugged ducts. So sometimes it's not a matter of it being something, an issue within the breast. Sometimes it's an issue with the way the baby's latching and the way the baby's removing the milk. I find this quite a bit with kids who have torticollis, where the head's kind of stuck in one position, or they can only turn, say, to the right. Moms will tend to get mastitis just on one side, and the other side is fine, or they have pain with breastfeeding on one side, the other side's fine. But babies that have issues with latching, whether it be from a tongue tie, whether it be from torticollis, if they have plagiocephaly, if they have their shoulders are up by their ears, their back is restricted, they've got a shoulder that's restricted, the neck is restricted. If any of that is going on, that can translate into poor milk removal, which can result in mastitis. And I know you have lots to say on this
Yeah.
too.
I see a lot of issues. Simply sometimes it's just latch and positioning. It's like the position isn't allowing for a deep enough latch, which can cause issues outside of all of those other things that you mentioned, Mary Ellen. Um, and breech babies are really interesting babies because they just are often are just stuck up in their shoulders because that's how they had to be in utero. And even after they're born, people don't realize like we need to get them out of their shoulders. So like I often like will show some gentle like neck stretches or whatever. And if that doesn't work, of course, I refer to PT to like do the releases that actually will help the baby be able to move properly. But sometimes when you catch things right after birth or like within the first few days, just helping parents realize to support the neck and not the head only, and kind of get the neck, the head away from the shoulders and drop the shoulders down. Sometimes that it'll take care of itself and there won't be a need to refer to PT. It's often when those issues just they're ongoing. And
Hmm.
I also find that you really are in a pickle when it's both a breast issue and a baby latching and removal issue. And then like those chronic reoccurring issues just keep, and sometimes it's like chicken or the egg. Like, was the baby, latching shallowly because of a breast issue or did the breast issue start because of the shallow latch? And, or like, reflux sometimes, like once babies are refluxing a lot and they're having discomfort with it, that creates a lot of restrictions in the body that then in turn creates poor latching, which then in turn creates breast issues. And then, so it's really, fortunately, oftentimes it's more complex than we would like it to be. It's not as
Hmm.
straightforward as we fix this and boom, everything is great. So just keep that in mind when you're thinking about this and dealing with it, is that there's like multiple variables, two different bodies, and that are meeting together as one that create a lot of these issues.
Yeah, absolutely. Absolutely. Another issue that is going to take it, we're going to have an entire podcast on this alone, but tongue tie is a huge one for a baby latching poorly and that leading to mastitis. I have seen that. I can't even count how many times I have seen that where the tongue tie is not allowing that tongue to move properly, not allowing that latch to happen properly, and that leading to mastitis.
Mastitis and low milk supply. Oftentimes, babies with tongue ties can sometimes they'll do really good in the first 2 to 3 days post delivery. And then the milk volume increases, and also the swelling and edema of engorgement happens. And then it just all things go bad. And some people, I'll even see families that, like, with really great lactation support, sometimes even after seeing you, that have continued to decided not to release or didn't have the means to release the tongue tie, even if they wanted to, they like we start seeing more issues at like 3 to 4 months. And then also, I've seen a couple of babies where like everything was going great with breastfeeding except for the first 2 weeks was super painful and some damage to the nipples, and then 9 to 10 months we're seeing issues again. So like sometimes people are like, well, once the baby's learned how to latch, like what do you need to be around for? And I'm like, oh, there's issues that can pop up at any time.
Hmm.
So
Yeah.
yeah.
I always tell my parents that I work with that, okay, I released this in the baby. I don't know how long this was present in the baby. Was this from the birth itself? Was this from how they were positioned in utero? Were they stuck in this position for 2 weeks or 3 weeks or 4 weeks? Were they stuck up under the ribs in the case of a breech baby with the head, turned one way, and now they have like a massive torticollis, a massive plagiocephaly. They're in a helmet. So, I mean, there's like that extreme, and then the other extreme is like, okay, they're just a little stuck. Um, that even when I do the releases as they grow, all of a sudden it's like, oh, they're stuck again. Well, they went through this growth spurt and the tissues didn't grow at the same rate. And this is a little tighter over here and that's not as tight over there. So, yeah, sometimes down the road they need, a periodic tune up so we can keep up with the tissues.
Yeah. Also the reflux, or like even I've seen it with babies that have gone on like long car trips where they were in a car seat for like, you know, almost the entire day with like short little 30-minute breaks, that sometimes just all of that being in one position will cause issues later on. So,
This is a little guy that Kat and I had worked with. You can see on the left, this is a picture from when he was 1 month old. He's really, his whole trunk is rotated or kind of side bent to the left. His head is bent to the left. He looks like he's in a C shape. And that is not just the way he happened to be put down. That is exactly how he would be if you put him down. Even his head, for those of you that can see the pictures, he was heading for a helmet. And his pediatrician had told them, oh, just wait, we'll get you to the craniofacial doc later on down the road when he's ready for a helmet, rather than referring for PT where we could um, really make a huge difference at this age where the fontanelles are really still wide open and we can really, really help with the tension in the body. I worked with him once a week, and the picture on the right is with him really, the trunk is straight. His head is no longer misshapen. Um, his right leg is still kind of turned a little bit. He still needed just a little bit more treatment for that. But wow, did those couple of treatments where, it was 30 minutes once a week that I worked with him, straightened him out that much. But the result of him trying to latch was causing mastitis in mom because of all of those restrictions in his body. And I'm sure that I'm missing something with that case, Kat.
Oh, with his story.
Yeah.
And I just want to say thank you to the mom if she sees this for like sharing those pictures with us so that we can educate more people about it. This precious one had a tongue tie that was released prior to this 1 month picture. Mom had was it caused low milk supply because of all the nipple damage and issues that mom had in the first week postpartum. The doctors and everybody was just like, oh, just triple feed. Oh, just do this. Like nobody was trying to really support or assess or deal with the root cause of what was going on with this baby, which was all of these restrictions in the body. And mom, like oftentimes, like, this baby actually would drive 45 minutes to an hour to see Mary Ellen for 30 minutes and then back 45 minutes to an hour. I did home visits for this family, and I would come to the door, or mom would come to the door and would always have to have baby in a way that supported this left leaning position. And if you try to move the baby out of it, the baby would like just lose it, would scream, would holler, would cry. Mom also had breast implants. So this is kind of one of those situations where it wasn't just the baby, it was also mom's breasts. So because breast implants, while you can, and please don't let anybody tell you differently, I see this a lot. I work with a lot of people with breast implants. You can breastfeed. But very commonly, there's two things that happen with women that have breast implants that continue that breastfeed successfully, is that they kind of always have this like artificial engorgement because the implants are just kind of putting pressure on that tissue, and there's just something else added to the situation. And also, the simple presence of the implants sometimes just causes reoccurring dysbiosis of the breast, which will lean itself to mastitis. So, like those two things together, and the baby being looking the way the baby is in that first picture, really created like a perfect storm for needing a lot of care. And I was very thankful at that time that I was able to see that patient, that dyad, very, very frequently with insurance. And I think that that combined with the visits to you allowed this family to meet their goals. And this baby was breastfed for over a year and breast milk fed, and also has a baby sister now who is doing pretty
Oh,
gosh darn good too.
awesome. Awesome. I hadn't heard that one.
Yeah.
To wrap up mastitis, breast issues almost always mean milk removal issues. So sometimes it's how is the baby latching? How is the baby sucking? Sometimes it's what's going on with pumping. Um, is the pump at too high suction? Is the flange the wrong size? Or is mom maybe overproducing milk and drowning the baby? And the baby has to like guard against the flow that's coming out. So, Kat, anything else you'd like to add in our summary?
Um, just that, like looking at the whole picture and looking at the dyad as one thing, even if baby is exclusively being bottle fed, is just very important.
Yeah. And by bottle fed, it's like the, breast milk going into the
Yes,
bottle.
yes,
So it's a mom's pumping exclusively and
yeah,
feeding the baby breast milk.
yeah.
Yeah, so like the whole picture. All right, I hope you enjoyed our podcast here on mastitis. Thank you very much for listening, and we'll catch you next time. Bye.